vision of what we would like. And sometimes you have to take a risk on love as well. Some people will swipe on anything, literally, and some people will be like, no thanks. That's risk appetite, right? It's not just whether you say yes or no, it's about knowing your boundaries. It's also kind of knowing what your values are before you jump in. It's about understanding the uncertainty and to use that compass, that risk appetite compass, to help us navigate that uncertainty. So, no, if you're wondering, you're not in the wrong presentation. I also wanted to bring up that the average adult makes 35,000 decisions a day. 200 of those are about lunch. So I understand that I am the session about lunch, just for lunch, and I'm on risk appetite, so I will not keep you away from lunch today. We're going to talk about a couple of things today. Key ones are what is risk appetite. We're going to level set for everybody in the room. I know we've got some awesome students in the back from Typo's classes and AUT. We're going to talk a little bit around appetite tolerance and capacity, again, just to level set. We're going to talk about who Plunket is and why I work there and why would we need a compass. And 2 case studies, a little bit around growth and stability, and then a little bit of where you can find me, because again, I'm not going to eat into lunch, please. I need it too, I might get hangry. So, kia ora, ko Nicola Āwhina, no Āwhina ki te tonga o. I'm head of safety risk insurance at Whānau Plunket. It means I spend a lot of my time in frameworks, in systems, in audits, in compliance, in quality. I wear a couple of hats. And I do a lot of the things around the structures that keep our people safe. But my real focus, and honestly kind of what gets me up in the morning, is the human side of risk. The part where we ask, is the system actually designed with our people in mind? So, also, he taki wātanga o, my current type of fixation is writing journal articles, hilariously. I've just finished my Master of Law, and a lot of these deep dives for me have sparked a huge drive to publish more research, especially around women in leadership, especially now around neuro-inclusivity. And when I'm usually speaking, I'm unpacking terms like regulation, assurance maturity. But today I'm kind of interested to change the lens a little bit and speak on risk appetite. So, because this is not just another kind of tick box item or a governance tick box item, it's actually one of the most relevant tools we can use within our organisation to align our values with what we're actually doing in our strategy. And if we get it really right, it becomes that strategic compass for us, not just where we want to go, but where we should go. So a little bit about why I work for Plunket. This over here is my Plunket baby. And I'd also like to point out, my partner said I should put more pictures of babies and also a picture of the donate QR code because we are a charity, picture of baby. When I came to New Zealand and I was going to have my son, first time mum, didn't know what I was doing, I was considered high risk for postnatal depression. At about 3 months old, my son had a pseudo-near-miss, which is a sudden, unexpected infant death incident, and he was rushed to hospital and he spent a couple of days there. My Plunket nurse had already identified that I was high risk for postnatal depression, and they had stuck with me through this entire experience. They had been a calm word in the background, they'd given me resources, advice, and information. Honestly, it helped me get through. So when this job came up, what a treat, I knew that it wasn't going to be just a job for me. It was going to be my chance to give back to our nurses. It was going to be my chance to give back to the organisation that helped me. And that's what Plunket does, is we show up quietly, consistently, in the background for whānau across Aotearoa. So, what is Plunket? Hands up from my crew over here. Hands up if you were a Plunket baby. Great. Hands up if you have a Plunket baby. Hands up if one of your grandchildren is a Plunket baby. Excellent. All right, so this little introduction is for those of us that are not familiar with Plunket. Plunket is Aotearoa New Zealand's largest provider of health and wellbeing services for children under 5. We're a charity. Our job is to work with Whānau at the earliest and probably most critical years of a child's life. We provide, and the list is extensive because the entire team helped me with this list, checking development, health, growth, and milestones, parenting support, and advice, because let's be honest, sometimes being a parent sucks, home visits, clinics, connections to community support, breastfeeding support. We have a 24/7 helpline called Plunket Line. We have postnatal mental health care. We don't provide hospitals or emergency care, but we are a steady presence that checks in regularly, usually in your home, to support families through those first 5 years. And while we get some government funding to donate, most of it is community support, which means we often have to be really strategic about where we stretch our resources and where we take risks and how we adapt those to meet our challenging needs. So why does risk appetite actually matter to us? We're just a charity, we're working with kids in Whānau. The margin for error is absolutely minuscule, but our need for courage is really high. So, we're going to level set. Super boring for those of us that are in the know, for those of us that are not. We're going to start with some risk 101. The top here is obviously inherent risk. This is the level of risk we face before putting our controls in place, which lead us to residual risk. Our controls obviously are the actions and safeguards we put in place, or the systems we have to manage risk. Risk appetite, now the other end here, is how much risk we're willing to take on. Risk tolerance is how much we'll accept before taking any action, and our risk capacity is our hard no. So here we're building a map before we choose the route that we're going on. What does it look in practice? When we map this out visually, and I just want to be clear, these are not our actual risks because my boss was like, don't do that. This matrix is just one way for us to map out our risk appetite in context. We obviously have likelihood and consequence running in either direction, and our color bands give us a really good indicator whether or not we're in that risk tolerance space. Our appetite, how much risk are we willing to take on? Our tolerance, do we need to act right now? Our capacity, can we even afford to carry this much risk? So for us, I'll pretend number 6, it's probably up in the area anyway, is clinical risk. This covers safety and quality for our services that we deliver. This is where we hold our highest duty of care, and it's where we apply some of our strongest controls, from staffing or staff training all the way through to robust clinical governance. Number 6 is without a doubt our highest risk, is our financial risk. As a charitable organisation, our ability to deliver services relies on a very complex funding model. We rely on balancing government contracts, philanthropic support, and community donations, all while demand is increasing. It is a free service. So when we talk about financial risk, we're talking about the real tension between the needs of our whānau and the sustainability of the system supporting them. At the lower end of the scale, number 17, we have things like regulation and compliance. We actually have really good controls and systems in place in these areas, so it's not that it's an unimportant risk. It's a good news story. It's that we've got really great controls in place, and it gives us far less anxiety than some of the others. So for us, clinical care and kind of the risks that we have on the screen don't map neatly into those dollar signs or KRIs or KPIs, because realistically, we're trading in well-being and trust, and as I think it was Sharon mentioned earlier, mainly in reputation. So our challenge is to hold space for risk while always keeping babies and family at the centre of that. So why does it matter? This is really big for us. Our appetite isn't just a governance exercise. At Plunket, our model of care is changing. We're moving from the passive see and refer to see and support. See and refer means that we identify a need when we come into your home, and we usually refer Whānau to someone else. We refer you to go to your GP, specialist, etc. Whereas see and support means we come into your home or you come into our clinic, and we can actually provide you the care on the spot that you may need. This shift brings incredible and very real opportunity, but also brand new risks. Clinical, reputational, operational. But when you're working with Whānau and you're working with family, we've got to remember again that margin for error is tiny. You don't want to hurt the baby. But we also need to be really courageous as to what we're going to do next. That's where risk appetite for us becomes really important. It gives us permission to act, not recklessly, but deliberately. It helps us take on more complex, high interest, high impact work, knowing that we've got the right foundations in place to do it safely. So our biggest risk, and again I think Sharon mentioned earlier, our biggest risk is not clinical. It's becoming completely irrelevant. So our first case study is immunisations. And I think Bindi from ProCare earlier mentioned quite a bit around the herd immunity piece. This is a shift fundamentally on the way that we look at clinical risk and the way that we do care within our communities. We've identified some serious issues. Tamariki immunisation rates are not where they need to be, especially to prevent vaccine-preventable disease. That's not a hypothetical risk. That is a very real public health concern. New Zealand's immunisation schedule against 13 serious risks or diseases is usually before the age of 5, and that includes things like measles, whooping cough, diphtheria, polio, meningitis, rotavirus, and a whole bunch. There's like a ton of them. Latest figures, again, as Billy mentioned, are around 80% of 3-month-olds are fully immunised and 79% of 2-year-olds are fully vaccinated. That is nowhere near the 95% target for herd immunity. But the picture is actually more concerning if you look at our priority populations. Only 69% of Māori 2-year-olds are fully immunised. Coverage for some Māori communities is only 35%, and it dips down to 44% in Pacifica communities. So even with high coverage in some areas and low coverage in others, we're still seeing massive outbreaks of vaccine-preventable diseases. Much like in late 2024, we had 1,400 cases of hospitalizations, mostly in infants. Not great, but a reminder that it's a fragile and vulnerable group. And history shows us that immunizations can lead to measles outbreak. We've currently got one in the Wairarapa, and in 2019 we had over 2,100 total cases with 700 hospitalizations. It's a fatal vaccine-preventable disease. So, of course, this shift carries risks. Clinical risk is we're now administering vaccines, reputational risk because of rising vaccine hesitancy, safety risks around needle sticks, cold chain, anaphylaxis, and tension in the sector. So if you came and talked to my team said hard no. Just no thanks. Get off the grass. But the risk of actually doing nothing is greater than the risk of stepping in. So we realized that holding a low-risk approach for clinical risk and staying in that refer-only lane meant that we were accepting the risk of inaction, and that for us meant a bigger danger. David talked about that risk tension earlier, and we deliberately shifted our risk appetite from conservative to moderate, and we chose to take on clinical risk in a controlled and strategic way. Not because it was easy, but because it was necessary. So we implemented very clear controls. We trained our staff, protocols established, rollout was staged and responsive, incident management, processes were in place, and we worked actively with communities to reduce that tension. The result? Increased access, greater reach, stronger protection for whānau, all without compromising the safety. That's a great example of how using risk appetite as a guide is also not a blocker. So it's a good news story. Here are just some snapshots of some of the immunisation pilots of what the immunisation pilot is achieving. With just these 5 sites, we've had, in the last month, 79 tamariki vaccinated in Kaikoi, Whānau, Taumara Nui. And behind the scenes, we've got 22 fully authorised vaccinators and 45 more in training, with cold chain systems and governance systems being built from the ground up in each location. Over the last month as well, this is not just people getting vaccinated. In the last month, we've had 14,000 whānau receive immunisation and education through well-child contacts and 500 calls to Plunket line around immunisations. We're scaling steadily. We've got another 10 sites that have been approved, and I think what's powerful here is it's not just about the numbers. We're seeing trust being built. Parents are walking in because they couldn't get seen anywhere else, and grandparents are booking multiple mokopuna in to come and grab a vaccine. Hesitant clients are being gently coaxed into confidence, and that's actually what impact looks like. Our second case study is around nurse prescribing. This is a really interesting one. Also, I got told I had to say the full name out loud: registered nurse prescribing in the community health pilot, or I would get in trouble. This was, again, born out of necessity. A Plunket nurse will go in to visit a child. They'll see conjunctivitis, skin rash, etc. Something the nurse knows exactly what that is, but couldn't do anything about it. They had to refer on to a GP, had to refer on to a specialist. Under the current system, again, can't do anything. So, next appointment is 2 to 3 weeks away to see the GP. There's cost issues involved, transport issues involved. There are many deterrents. And in this deterrent phase, the child is probably not getting the care that it needs. So the risks for us here were very real. How do we know that we can prescribe certain healthcare products to children between 0 to 5 under supervision within a tightly defined scope? This was really important to us. But again, the risks didn't stop us because we knew we couldn't treat them as deal breakers. Instead, we treated them as factors to manage. We looked at the risk appetite and said, we're willing to take this on, given the right conditions. We gave ourselves permission to take a moderate innovation risk in this space, but we surrounded it with very strong controls. The program is small in scale. It's externally funded, so the financial risk is contained. We brought in specialist expertise, including a nurse practitioner and pharmacology support, and there was clear prescribing protocols, keeping in mind that the safety of prescribing can be misunderstood because people will think we can do something cool like oxycodone. We cannot as panel. And we've been really honest. It may not work, and we're okay with that. But if it does, we've got some awesome learnings in place, and it could reshape our access to care, which is kind of our risk conference focus, right? The focus of the summit is together we can shape the future. So this is how risk appetite supports innovation without putting the whole organisation at risk. These weren't reckless moves. These were calculated steps backed by clear appetite and strong controls. We don't wait for perfect conditions, we wait for a space to learn, adapt, and lead. So at the heart of this all, we've got a little bit of balance. Both of these pilots were intentionally designed to be scalable, so if the model proves safe and effective and trusted, we can extend this across more communities without having to reinvent the wheel. But we're not perfect. We are going to be the first to say that we're not perfect. We're bronze level, I would say. Not all of our risks are tightly controlled, and our biggest one at the moment with both of these pilots is our exit plan. What happens if it does go wrong? How do we stop something bad from happening? especially when the reputational risks are so incredibly high. So we're not aiming for perfection at the minute, we're just aiming for transparency and adaptability and learning as we go. We need the risk to grow, otherwise we fall behind and we become irrelevant. So this is where risk appetite shines. And it says, yes, let's take a risk, let's give it a crack. Right controls, limited scope, give it a crack. And this is how we move from see and refer to see and support. Look, picture of baby, so the donate button. So this is my Plunket baby, 12 years on. New risks, by the way, just sorry. If you have any questions today, my name is Nicola, and honestly, I'm going to keep you for lunch. Like, I'm a psychopath would do that at this now. Cool. If you have enjoyed this deep dive today, though, I'm more than happy for you to reach out to me on LinkedIn, on anything you can find me on, wherever. Feel free to chat. I will judge you if you don't QR code though. And yeah, feel free to email me any questions you